Well, thank you very much indeed for those kind words of introduction. Let's get into this deep dive into psoriatic arthritis and find out where JAK inhibitors really fit into the treatment paradigm. These are my disclosures. What I hope to do over the next 10 to 12 minutes is talk about the multiple domains of psoriatic arthritis that we know our patients suffer with, outline what treatment options we have to achieve comprehensive control, and then think about where JAK inhibitors fit into that treatment paradigm. It's always helpful to start a presentation like this, just reminding ourselves about those many manifestations that people with psoriatic arthritis suffer from. Around 50% will have axial involvement. Obviously, the majority have peripheral articular disease and episodes of dactylitis, enthesitis. Most have psoriasis, and a small proportion have additional inflammatory bowel disease and uveitis. But I think one of the main things that we need to remember is that articular disease remains the main problem that patients suffer with only around a third of patients having more than 3% of their body surface area affected by psoriasis. And this is data coming from a number of different studies, including the Corona registry, now called Evitas, and the Loop study. But we know joint problems are the problem that patients suffer with most of all. And this is data from the MAP survey, showed that 79% of patients reported that musculoskeletal symptoms, joint pain, was the highest or most important factor for them, with other aspects like tenderness, stiffness, and swelling following behind. How should we be treating our patients? What targets should we be looking at? Well, ultimately, it's the lowest possible level of disease activity to prevent structural damage, normalize functional status, and make people feel better in all the ways they want. We know that a treat-to-target strategy works, and there are a number of different targets out there, from minimal disease activity, DAPSA, and others. But aiming for low disease activity or remission is the thing that will improve people's functional status. And how can we do that? Well, we have a portfolio of advanced therapies, including biologic drugs and targeted synthetics that have really been a paradigm shift in addition to our conventional synthetic DMARDs. Something that all of the treatment recommendations have in common is treat to target, and we have a number of recommendations that I'm showing you here just for illustrative purposes. The Grappa recommendations have just been updated. Of course, we have the EULAR recommendations as well as the ACR NPF guidance. And they all take a similar approach where they tell us which biologic and targeted synthetic DMARDs work in each domain of disease. I have an affinity with the Grappa recommendations, and actually as part of their update, you'll see that JAK inhibition is included as a treatment option for skin and nail disease, enthesitis, dactylitis, as well as those with axial involvement. When we talk about targets, I think it's helpful to acknowledge and accept that many patients fail to achieve remission states even with advanced therapies. And what you're looking at in these pie graphs are the proportion of patients achieving minimal disease activity, or MDA, which you're familiar with, in a number of different trials. And the intention is not for you to compare across these studies, but just acknowledge that many patients don't achieve minimal disease activity. So there is that area of unmet need. There is that need to move on and improve people's lives with further treatment options. It's also important to recognise that psoriatic arthritis is a lifelong disease, and people do discontinue their biologic therapy either through secondary inefficacy, side effects, or other problems. So we need to keep constant vigilance in terms of disease activity and whether or not the biologic or targeted synthetic drug somebody's on is the right drug for them. So we have tofacitinib and upadacitinib, and this slide is a description of those two study programs, the OPAL program for tofacitinib and the SELECT PSA program for upadacitinib. The SELECT PSA1 program is the only study that included multiplicity adjusted endpoints versus adalimumab, including non-inferiority and superiority for ACR20, and I'll show you some of that data shortly. Tofacitinib in the OPAL program did show that tofacitinib JAK inhibition improved joint outcomes in both people with biologic and conventional DMARD resistant patients. And you'll see here on the left-hand side ACR20 responses with tofacitinib, 5 milligrams of around 50% in the conventional DMARD resistant arm on the left and TNF resistant arm on the right-hand side. We also saw tofacitinib improve skin outcomes, and on the left-hand side, PASI 75 responses in OPAL Broaden and PASI 75 in OPAL Beyond on the right. Modest responses, I think we'd accept, with 43% of people achieving a PASI 75 in OPAL Broaden and 21 in OPAL Beyond. So that OPAL Beyond outcome did not achieve statistical significance. What about the safety profile? Here you're looking at placebo in grey, adalimumab in purple, and tofacitinib in pink there. And you'll see that the safety data was consistent with previous rheumatoid arthritis and ankylosing spondylitis trials. If you just take your eye down, you saw tofacitinib was associated with slightly higher rates of zoster infection, as you might expect. There were two cases of malignancy, and in terms of treatment emergent adverse effects at the bottom of this graph, slightly higher rates of nasopharyngitis and headache, upper respiratory tract infection. But these are not new safety signals, and they're ones that were previously consistently reported in RA and AS studies. Let's move on to upadacitinib now. And these are the outcomes from Select PSA1 on the left-hand side and Select PSA2, so that's biologic resistant arm on the right-hand side. And you'll see ACR20 responses of 71% with the upadacitinib 15 milligram dose versus 65% in the adalimumab comparator arm. On the right-hand side, you'll see ACR20 responses of 57%, which is a good response in somebody who's quite high numbers of people who'd had exposure to 3 or more biologic drugs, so quite a resistant population. So that gives us confidence that upadacitinib works over a short period of time, out to 12 weeks, and these data show responses out to 56 weeks. And you'll see 71% of patients in ACR20 at week 56. If you look at ACR50, which is a more meaningful endpoint in my mind, with 50% improvement, we see 60% of patients in ACR20 and actually 41% of patients in ACR70 at week 56. Well, that's convincing for joint disease. What about skin outcomes? And here you'll see PASI 75 outcomes of 63%, with 38% achieving a PASI 90 and 24% achieving a PASI 100 in Select PSA1. And again, as we've seen with the joint outcomes, quite high rates of responses in the biologic resistant study Select PSA2, with 52% of people achieving a PASI 75. So we've seen that upadacitinib can improve joint and skin disease. What about arresting radiographic progression? And here we're looking at the modified Sharp score, modified total Sharp score at week 24 on the left and week 56 on the right. And you'll see that upadacitinib afforded joint protection with progression seen in the placebo arm, but no progression seen in the upadacitinib arm. So confidence here that upadacitinib is protecting joints and preventing structural damage progression. What about these composite outcome measures? People don't come to us asking for an ACR20 or a PASI 75. They want to feel well in all the ways that they are suffering. So their skin, their joints, their pain, their physical function. And a lot of those are embodied in these composite outcome measures. I'd really like to draw your attention to the MDA outcomes on the left-hand side. And you can see here high rates of people achieving MDA, 36% achieving MDA with upadacitinib 15 milligrams in Select PSA1. There are also outcomes there for PASDAS and DAPSA at similarly high levels. What about axial involvement? Well, in the SELECT trial program, the BASDI 50 was taken for those with clinical axial involvement, and the BASDI 50 was significantly improved with upadacitinib, with 49% achieving a BASDI 50 at week 24. So finally, let's talk about safety with upadacitinib. And again, this was consistent with rheumatoid and AS trials. I'd like to draw your attention across the right-hand side of the graph with adalimumab in purple and upadacitinib in green there. And I think you'll agree, quite reassuring figures here. There were 7 events, so 1.1% achieved with herpes zoster, and I think that would be expected. And again, that's been previously reported in RA and AS studies. So let's summarize where JAK inhibition with upadacitinib has shown effectiveness. I'm going to take you from the top of this graph all the way around to the left. We've seen good ACR 20, 50 and 70 responses. We've shown PASI 75, 90 and 100 responsive. We've seen improvements in enthesitis, dactylitis and axial disease. And the upadacitinib is under investigation in the setting of inflammatory bowel disease. So with that, I'm going to summarize. I think the key messages I want you to take from this is that musculoskeletal symptoms remain the primary driver for patients living with psoriatic arthritis. There are multiple mechanisms of action available in the treatment landscape for psoriatic arthritis. But despite this, quite low proportions of patients are actually achieving clinical remission states. And therefore, there's this ongoing need for alternative therapies. And now we have JAK inhibition as an oral therapeutic option. And I've shown you effectiveness across the disease manifestations for PSA. With that, I'm going to conclude and hand back to Professor Oster to take us forward. Thank you so much.